ICD, but currently our policy says CIED, which is cardiac implanted electronic device. Okay, so wanted to just go over what our policy says along with following the AORN standards. So here, we want to make sure that we're doing patients that are obviously suitable for an ambulatory surgery center. We want to minimize the electromagnetic interference and manage the patient with either the use of a magnet or reprogramming if necessary. Okay, so unsuitable patients is on the next page. Patients with less than 40% LVEF, okay, and that's, they wouldn't be coming here. Any patients with decompensated new onset or untreated heart failure. Anybody with severe aortic stenosis or mitral valve stenosis. If they have symptomatic or new onset atrial fib, we wouldn't want to do that here. So other patients that are stable, totally fine. Now, what we want to do is make sure for us, we're collaborating with the pre-op nurses and with anesthesia to make sure of how we want to manage the patients. Sometimes they may ask for the defibrillation pads to be brought in the room with patients. That doesn't mean necessarily placed on the patient. When I talked with anesthesia, they said no, it would be perfectly fine to leave them in the package, but have them in the room and maybe have like the crash cart if needed with the defibrillator or AED outside the room, just so it's available. We may place the magnet over the device, but again, that's gonna be more of an anesthesia call, and you wanna make sure most of the time they're up here, but they can be on the side. You wanna make sure it's securely taped over the device and doesn't move. I have seen it where I've actually come into a room, other places where supposedly it was over the device, but the tape was so loose it had actually shifted up and it wasn't. So it's important to make sure that that tape, if it's on there, is secure. We want to try and encourage them to use bipolar cautery if it's possible versus monopolar, since monopolar is going to tend to interfere with that electronic device. Use the lowest setting possible, and then we also want to make sure that they're using short bursts. So they can't just go in there and be cauterizing, for long periods of time. So when they're cauterizing, we need to make sure we're looking with anesthesia at the monitor to make sure patient still has a rhythm. We don't want them to go into asystole because the device isn't functioning. You want to make sure when you actually, if you have to put the defibrillator pads on, you don't place them over the device. That would be a big no-no. So you want to make sure you either put them, and there's pictures on them that you're going to place those. You can either do one side and opposite or front and back, depending on where you're working. The important thing is to make sure when you're putting like a grounding pad for the cautery equipment that you're not crossing where that defibrillator is. Otherwise, the energy is going to be going through that device. So trying to stay away from where that device is placed. If we can stay opposite but not too far away from the site, that's typically going to be ideal. So anytime these patients are going to be done, they should be on a monitor, and pre-op be monitoring their rhythm the entire time. When we take them back to the OR, anesthesia is going to be monitoring them the whole time, and then when they go to recovery, they need to continue to be monitored until it's deemed that they're okay. If we've used a magnet and placed it and taken it off, we need to make sure that it's working appropriately. Most of the time, they don't need to be interrogated, but if it doesn't seem to be functioning appropriately, we need to obviously contact somebody to come in and interrogate the device. Those are probably the biggest things. I think I ran through everything pretty quickly. Questions? No?
No questions?
Wow. Okay.
Wow. Well, that was a very good job. Yes, you know. So my name's Ned Orth. I'm with one of the CRM companies, Biotronic, and just to expound on what you've been told. I mean, most of the time you're gonna, you know, the cardiologist's office has already been engaged, you know, by the surgeon's office, and they're supposed to fill out a form, and that's supposed to come in on a sheet. I'm sure you've all seen it. So it's really all about the communication there and making sure everything's clear. Most of the time the cardiologist's office calls us, the reps, because they don't really know exactly what the parameters should be or what the policy should be. And again, you have your specific institutional policy here. It could be different elsewhere, but overall, this is really actually very close to what we see just about everywhere. And but there's always those instances where it becomes a panic situation. And so in that case, when in doubt, you know, putting a magnet on a device is never, you know, there's really no downside to that. For a defibrillator, the idea is to actually disable the therapies that could be delivered, such as a shock or anti-tachycardia pacing. And it used to be that we would come in and program these devices off for the surgery, pre-surgery, and then program them back on. And we quickly found out it's actually better just to put a magnet on, because if the patient intraoperatively goes into a bad arrhythmia, it's much easier to pull the device off, allow the device to reactivate and provide therapy than call the rep in, who may be, you know, 3 miles away and doing something else to come in and try to do something. So, which is also why you have the, you know, you have the crash cart or the, you know, the monitor in there anyway, and the pads. As far as device reaction, a magnet in a pacemaker will make it blind to any EMI. So, you know, essentially from cautery, which is what you you know, experience here more than anything. So it'll disable that ability. It'll make it blind, and then when you pull it off, it'll go right back to its regular mode. It's very rare that we see a reed switch, which is what is activated inside a device stick, and then they just stay in a magnet mode. And a lot of times that won't even be caught, you know, until the patient starts to complain about, you know, 2 days later that, gosh, they don't feel right. But you know, in 25 years, I've seen that maybe one time. So, as far as the defibrillators, again, it just disables the therapies. You pull it off, it'll go right back to it, you know, enabling its therapies. And it's rare that we come in anymore to have these devices programmed. It's only and a lot of times if you're going to operate on the area where it is located, such as breast augmentation surgery or anything like that, a lot of times they will move the device over. If it's that serious of a surgery or that important, they'll actually, the electrophysiologist will move it over to the right side in another procedure before they even do the breast surgery. So it's pretty simple. But I know how it is intraoperatively. You just, you know, you get into a situation where you're like, do I or don't I? If you get into that situation, just put a magnet on there and make sure it's over top. And most of the devices nowadays are small enough that they can be implanted up, you know, here subpectorally, either this side or that side. But you still will run into the abdominal implant every once in a while that the leads have been good, and when they go to do a generator change, to just stay with the abdominal implant. Or you have subcuticular ICDs that are implanted. The device itself is underneath the right here, yeah, right on the side. Other than that, we now have devices that are leadless, and so, you know, they take all, you know, that takes on a whole new realm. But and ours isn't out yet, so I don't know what they do, but I imagine they would have to be programmed, because I just don't think a magnet would be strong enough to elicit a response through all the tissue and inside the heart. So, but I don't know that you've run into that yet.
No.
Other than that, any questions? Do you think of any scenarios? Because it's once you all get the patient, everything is in place. You should know, and the decision made whether it's going to be a magnet application or not a magnet application. You don't. Not all these procedures require that. again, we're rarely called in for it anymore.
We used to have anesthesia in the room when we used to have to use the magnet, but is that still the case, I guess?
It's a good question. I mean, ACLS, you know, I think it's institution to
I mean, I
institution.
think that they should be.
I will.
I guess I don't know of any procedures we're doing here where we would not
They're
be
local.
having them.
What if they're local?
So, yeah, local procedure, I think you are gonna develop some, a new procedure, code or whatever for that. I mean, yeah, because,
Bipolar.
you know,
Bipolar.
you know, bipolar, or if it's monopolar, just short bursts. Now, if it's local, or do you necessarily have them on a monitor? Or is it just,
We just do blood pressure and pulse.
yeah, so, you know, it's very rare if it's not near the device itself or not near where the lead is. So think about your device is here or here. Your lead, if it's a ventricular based device, will be in the right ventricle. So the lead is here. So it senses from the lead tip to the device sometimes, or from the lead tip to another area of the lead. But either way, it can be a big antenna. So you have to keep that in mind. But for local, you may have to develop a new protocol.
So what about, like, they have that and then they have all this hardware, like Sharon was just asking me this, asked you this about a Bovie pad. Like if they have hardware everywhere and that pacemaker and everything, so where do we put the pad?
Well, you always try to be, what's that big word that's in there? Ipsilateral? I had to look that up because I forgot. But that same side, if you can, you know, because, you know, the cautery, the current's going to go take the path of least resistance, right? So if the device is here and you're doing, say, surgery right here, put the pad around here. Now, if they have a total joint, right? I know. You come in with the bionic patient, right? They come in, they've got new knees, new hips, and maybe a shoulder and elbow or something, you know. Then you just try to find an area that's on the same side, that flank.
I would try and go flank.
Yeah.
We've had them. They got hardware in their back, they got their hips. It's like, where do you put it?
Right. So,
Back of your head. Just put on their cheek.
right, because, you know, with those if you don't know if that current's going through there, if that's going to do anything, if it's going to elicit a response that you may not see for 5 years or 2 years, but could it, you know, elicit a response that could end up in avascular, you know, or some sort of necrotic situation down the road. So I would say try to go to the flank, you know, on the arm, you know, it's really, and just have them, you know, as still as possible. You're going to run into situations like that. They're pretty rare, but I mean, it's rare to have somebody that's really completely bionic. But if they, you know, I always say, you know, in the EP lab in the hospital, they're always asking the patient, do you have an implant? And then they try to stay ipsilateral and just stay on the same side if there's any way possible. That way that bipolar current's going to go stay away from the lead tip or the device. In 25 years, I think of one incident where magnet application didn't work, and that's because they put it in the wrong area. They thought it was in the right spot, but it wasn't. It was a defibrillator. Patient was shocked 6 times. That was painful, and for the patient, for sure. But it's just rare to see a bad outcome, right? I mean, and if you're in doubt, put the magnet on there. All the magnet does is close that reed switch so that it goes blind. And then when you know, some patients may be a little symptomatic with that type of pacing, because it's just going to go blind and it's going to pace at a rate of like 90 or 80 or 100, depending on the manufacturer. I mean, a magnet response is how we sometimes determine where the batteries, you know, if we don't know anything about the device, whether the battery is near end of life or at end of life, or if it's okay. And so all the manufacturers have their own rate, you know, that is just specific to their company, but it's either 80, 90, or 100 usually. And I mean, you just don't see too many bad reactions. We just don't, in all honesty. I haven't been called in for a long time. Even at the hospitals where they do the major surgeries, anesthesia is just like, if we're in doubt, we put a magnet on it. I very rarely get called by Christiana or St. Francis to come in. You know, MRIs, but not for something like this. The EMI and MRI is huge, so you have to do something. You have to do programming for that. But it's actually basically put them in the same mode as what a magnet does. Yeah, that's it, really. There isn't a whole lot else to it.
Thank you.
Thank
Sure.
you. Thank you.